going to move forward with the balance of our program. Vince, would you like to introduce our speaker?
Tonight's speaker is Raj Kapila. He's the Chief Infectious Disease at New Jersey College of Medicine and Dentistry. He has a long history of, pardon me? He has a long history of important positions over the past years. One interesting one was he was the Assistant Chief of Medicine for the U.S. Army in Okinawa during the Vietnam conflict. Dr. Kapila is attending physician and the epidemiologist at University Hospital in Newark. And now our speaker.
I want to thank the Men's Club for inviting me and Dr. Sethi. And I want to say good evening to all of you. I have been doing infectious disease now for probably half a century, ever since I came back from the Vietnam War. And I have no conflict of interest at this stage. And I'm going to talk a little bit about, as I said, quickly the clinical manifestations, the variants or the mutations, the management, and of course, the vaccines. Now, this belongs to the group of viruses called the corona, and SARS-2 is one of the coronaviruses, and it causes the disease called COVID-19 because it started in the year 2019, sometime in December. So there's no doubt that there's sometimes confusion between COVID and SARS. SARS is the virus and COVID is the disease. Now, yesterday, and this is a sad reflection of what is going on, in the entire world, there were more than 117 million cases, about 2.6 million deaths, and there are still 27 million. And I think this is a tip of the iceberg as far as I'm concerned. There are probably many, many, many more undiagnosed cases, especially in underdeveloped countries. In the United States, we have had about 2.9 million cases. But what is sad is that in the last 24 hours, we've had 56,000 cases. And the total deaths have been more than 500,000, more than 500,000. This is really not acceptable in a country that has probably one of the best healthcares. But you can recognize there are many, many factors why the death rate was so high related to every aspect of the problem that we can discuss. Now, what do we know about the coronavirus? These are viruses that cause usually the common cold, mild upper respiratory diseases. But recently, in the last few years, and where do they come from? They usually come from animals. And these three viruses, which are mentioned here, are probably all related to bats. The bats are immune with these viruses. They don't get sick. But if it comes into an animal and the human is exposed to that animal, for instance, there are camels in the Middle East. They call it the MERS syndrome. The second virus is what we call SARS-1, that was associated with civet cats in the Guangdong province of China. And third is this nightmare that we have now, the coronavirus disease, COVID-19, that comes from SARS-2. We don't know where this SARS-2 came from. There's a lot of speculation, but likely it came from a bat, went into the human, through an intermediate animal. We don't know what that animal was. So that investigation, unfortunately, has been delayed. And I don't want to go into the politics of that. But unfortunately, we don't have a clue as yet how this virus established itself in the human. Now, the coronavirus is a very pretty virus. It's got these spikes, as you can see, and it's called corona because of the crown-like appearance that you see. Very quickly, it spreads, obviously, just like any other common cold, through respiratory illness. And once it goes into a person, for instance, influenza will cause maybe one infection or two infections for every infected individual. This one can go up to 5, 6, 7. So it's highly more contagious than the usual flu. Now, where did it start? Again, that's not controversial, I think now. It started in China, in Wuhan, which is a very big city, and it might have been related to the seafood. And as you know, these live animals are brought in. Some of them are very exotic, including porcupines. So these animals probably were the source. The other, of course, the big controversy, there's a huge viral laboratory in Wuhan. So it's not clear, and there's a lot of controversy and discussion on how this virus escaped into the first human. But it started in Wuhan. That's no doubt about this. Now, if you are interested, you can read this report from WHO and the China Joint Mission. Some people think it's highly not very clear. I think there's a lot of issues related to this. And WHO was not allowed to investigate for about 8 to 10 months at that setting. Now this spreads, as I have already told you, like flu. These are little droplets. When you talk, when you cough, when you sneeze, this droplets get into the atmosphere. And they can migrate throughout that area where the individual is. Now, people have said about 6 feet is the risk factors, but I think the data is not clear because it's been suggested now that some of the strains can be transmitted even at a longer distance. So this is not clear. 6 feet is the one that the CDC says, but I think some data is suggesting it may be other areas. Now, as far as the variants are concerned, we started off with a native virus that everybody knows. And that was the original virus that came from Wuhan. Now what has happened, just like all viruses, they constantly have mutations. That means they keep changing their genetic material. So these several variants have occurred. I've listed them here. The first one was in United Kingdom. They sometimes call this the Kent virus. And this is probably the one that has emerged with a large number of mutations that is spread all over. And we have that in the United States, Canada, and Australia. Then there is the South African strain or variant, then the Nigerian, Brazil, and most recently, the last couple of weeks, there's a novel strain that has been identified in New York. And about 12 to 13% in one area, this strain has dominated. So we have our own strain in the United States. Now, why are we worried? Because some of these strains, there are 3 things. The transmission rate may be increased with these strains. That means their able to infect people in a much better way. The second thing is that do the vaccines protect against these new strains? And there's a lot of work being done. There's a suggestion, for instance, that some of the vaccines will not work in some of these strains, including the Brazil strain and the South African strain. And thirdly, do these variants cause more severe illness or increased risk of death? Yes. The United Kingdom strain has been shown, and all this data is rapidly emerging. It's impossible to keep up. Every day, every week, every day, every hour, there's a new publication related to these strains and how they are affected. Now, should you get tested? Yes. If you have fever, cough, close contacts, recently traveled, definitely get yourself tested, because you want to know whether you have now been infected with this virus. And obviously, you must call the healthcare provider before going to the provider's office or emergency department urgent care, but they will put you in isolation if they suspect that you have been exposed to this virus or you have symptoms and clinical illness associated. Now, how do you test it? The best test is still what we call reverse transcripted PCR, polymerase chain reaction. It's a little complicated test, and they put the stuff up your nose, and they take the sample and they process it in a very special lab. There are also antigen tests, but these antigen tests have a lot of false negatives. If you're positive, but the false negatives, that means they don't measure the antigen. So even though you may be carrying the virus, the antigen test may be negative. Now, it is clear that there are lots of viruses. There are 14 other viruses, relatively benign, not as bad as SARS-2 or COVID disease, that should be investigated. So when the specimen is taken, you also do a rapid screening for these other 12 to 14 viruses. Now, why? Because suppose you have influenza, we have treatment for influenza. So it is important. And there are cases now where both the viruses, influenza and SARS-2 or COVID infections have occurred. Now, very quickly, it is known that antibody tests, that means once the infection occurs in your body produces an immune response, and those are antibodies. Now, these antibodies have really not been approved by the FDA, but they are being used and does not recommend use for serological tests as the sole basis for diagnosing acute SARS-CoV-2. And we'll talk a little bit about it when we talk about vaccines. So most of the time, these are not needed, and your insurance may not even pay for it. Now, the other issue is, obviously, these antibodies, they are IgG and IgM, and they are neutralizing antibodies. They definitely are the major immune mechanisms by which this virus is contained. So there is no doubt that they are very important from that point of view. Now, how long does this immunity last if you get infected? Nobody knows. But there is a gross figure of 8 months or even longer, because this disease is so new. So immunity can occur after developing COVID-19 or from getting the vaccination. And it's not clear again how long these vaccines will last. Now, if the variant occurs, which we'll talk about, then obviously you may need a second shot for the variant. And but it's still clear that social distancing, mask, and of course, hand washing are still critical. Now, there's no doubt that there's a lot of data, and some of it is very controversial, that the risk of morbidity, that means complications from this disease, is higher in certain racial and ethnic minorities. The Afro-Americans and also the Hispanics, there's no doubt. But some of this data is not known. It is probably related to the fact there may be work environment with higher risk. People go to areas where there is more exposure. Of course, economic inequality, living in close quarters, in crowded conditions, lack of healthcare, etc. But the other issue is very clear, that the comorbid conditions of cardiac disease, diabetes, hypertension, obesity, and in my judgment, obesity is very critical in causing this high risk of death and complications. Now, the incubation period is about 14 days, can extend to 14, but usually after 4 to 5 days of exposure, people start getting symptoms. And symptoms are cough, and then, of course, fever and shortness of breath. The presentations I've already listed here. And luckily, if you look at all the major epidemiological data, 80% of the positive confirmed cases will have mild illness. But if you are older, you have obesity, diabetes, and these other underlying comorbid conditions, then the risk becomes very significant. So that needs to be understood. Now, there are 5 stages of the disease. You may be totally asymptomatic or even pre-symptomatic. You may have mild illness, but normally mild illness means that you don't have the shortness of breath, or if you take an X-ray, you don't have positive findings of pneumonia. Then moderate, where your oxygen starts going down. Severe illness, of course, you are in very bad shape. At the time, your oxygen is way down, you're breathing rapidly, and critical illness is, of course, what we call the cytokine storm. The body releases these cytokines because the virus invades certain cells in your body. And this storm causes what looks like a typical septic shock. You go into shock and you get multiple organ failure. Your kidneys fail, your liver fails, your heart fails. This virus has the capacity to attack almost every end organ. So initially, we all thought it was only lung, but no longer true. Dr. Schwartz, who you've heard, is a professor who's written extensively and worked on the skin manifestations of this disease. And believe me, it's impossible to predict what starts this and how these patients end up. Now, reinfection can occur, and viral shedding can go on for days or weeks. But if you do a test, it just shows you have viral RNA. You have made the particle, but you may not have the virus itself. Now, clinical infection has been clearly associated and improvement with IgG and IgM. But these recovered patients, the upper respiratory can be up to 3 months after the illness. So this is one virus that hangs in there for a long, long time. And one has to be very careful in this setting to recognize this problem. Now, the clinical management, we leave it to doctors most of the time. But mild to moderate can be treated even at home, not moderate, mild. And you have to do what you do for a cold. But as the disease becomes more serious, and if you are elderly, you have obesity, heart, lung disease, etc., then you need to be monitored very, very carefully. The strange part of this virus is that you may feel well at 12 in the afternoon, at noon. And unfortunately, 1 hour later or 2 hours later, you may be intubated. So it's impossible to predict how this disease progresses. So it's critical to recognize this problem. It is critical to recognize this problem. Now, as you know, in the management, there's a lot of antivirals that are being used. The only one that is available now or has been approved by the FDA is remdesivir. It is an interesting antiviral agent, but a lot of new agents are being investigated. Everybody and his mother wants to get into the act, partly because of finance and partly, of course, it's such an interesting, unusual disease. Then there are immune modulating drugs. And then, of course, antiviral antibodies. Some of these, of course, as you know, our ex-president got. So there's no doubt that this is still being investigated. All these three areas: antivirals, immune modulating drugs, and antiviral antibodies. But it's clear that every day we are seeing new data on these agents. So I think there's a lot of work being done. Now, I have to tell you the red flags. If these are the red flags that will tell you immediately, or tell a doctor that the patient is now critically ill. And there's no doubt, most of it is related to the fact there's not enough oxygen in the body. So there is no doubt that this is very critical to remember that this virus can rapidly, on feeling well, 2 hours later or 1 hour later, you may end up getting intubated. Now, severe disease, you have to be hospitalized. And the unfortunate part of it is that the pneumonia is a very critical issue. Also, this virus is so strange, it attacks the blood vessels and causes severe vasculitis, inflammation of the blood vessels, and also wherever there is a heart has a blood vessel. So wherever there is a blood vessel, it causes blood clotting. The blood clots. So thromboembolism occurs. It also causes neurological illness in the brain, in the spinal cord. So there is no doubt that when you look at this virus, it constantly is being reported as causing multiple end organ damage. Now, obviously, a lot of work is being done, and this is evolving knowledge, and there are a lot of controversies on the management of COVID. Now, there are some that used to be used, hydroxychloroquine. Most of the data shows that at this stage it's not used and it's not effective. So there are good studies being done looking at what agents were initially being used and now have been discarded. There's another one called ivermectin that again is controversial, but we don't have all the data on that drug. Now, the last sentence here is interesting, that Merck, I don't know, my friends wanted to know whether they should invest. I don't know. But just like we have influenza treatment with oral drugs, Tamiflu, and the new one is Balaxavir, at least in ferrets, this particular drug, which is an experimental oral drug, suppresses the virus. So it's interesting that if this group of drugs, which is now being investigated in humans. Ferrets, yes, it works. Now, ferrets are maybe a little different than us, but in humans, it's being investigated, and hope that one of these drugs of this group will work, just like we get the efficacy with antivirals for influenza. So that is clear. You know for a fact that if you get what looks like flu, you go to your doctor and you don't need a test, believe me. You should be put on the antiviral drugs if there's an epidemic in your community or in your area, okay? Now, the other nightmare of this disease is that it has long-term or late, what they call long-haul problems. Persistent symptoms have been seen in survivors, even with those with mild illness. And these symptoms may pose new challenges to healthcare workers, and people have had all kinds of problems. Any end organ, for instance, this thing called fog in the brain syndrome. People can't remember things, can't think. They have delayed response to their work. So it's interesting that long-term sequelae is a problem that still is being investigated. And there's no doubt that this is going to create, amongst the survivors at least, that this may be a very serious issue, depending on, the work that is being done on how long this virus can affect the body. What are the late sequelae? Everything. Fatigue is very common. Cough, arthralgias, chest pain, depression, myalgias, headache, fever. And the most serious ones is heart, the lungs, the kidneys, the skin, the brain, and even psychiatric illness. So it's a sad reflection that this virus may leave you. You may come out of your intubation, but when you go home, there's no way to predict whether you're going to have the long-term consequences of this virus. Now, very quickly about vaccines. Vaccines normally would take 5-10 years to make. Luckily, I think the scientists realize that we have no time to waste. So they normally have phase 1, phase 2, phase 3, phase 4. All these were done within a year. And I must say that was very, very remarkable. And we have to give credit to the scientists and the people who thought of this and started working on these vaccines. Now, there are two types of vaccines. Those are messenger RNA, which you know are associated with the genetic material in the virus that is taken. There's a lipid layer and that is introduced. Now, there was a lot of discussion whether this messenger RNA can mess up your your genetic system. No longer true. This is all rubbish because the messenger RNA is destroyed very quickly. It does its job by producing an immune response. Antibodies are produced, as you can see, and then it is destroyed. It leaves. It doesn't cause any genetic material. So people, initially thought, oh, would it cause some major problems related to changing your genes? It doesn't go into your genes. Same thing with the DNA virus. This virus is then, part of this virus, the DNA is introduced into another virus, which is a benign virus. It's not a malignant virus, called adenovirus. And the adenovirus then goes into the body through the injection. And I'll tell you, the new one, which is you heard is Johnson & Johnson or Janssen. They are the ones who make these antibodies, but these are DNA virus. And again, this does not get incorporated in the human cell DNA. So please remember that and pass it on people who think that it may change the genes or cause DNA transformation. Now, there are about 154 vaccines that are being used, 21 in phase 1, phase 2, phase 3, only 11. And now we only have 3 in the United States. Moderna, which is a messenger RNA, Pfizer, which is a messenger RNA, and then Janssen or the Johnson, which is, as you know, the DNA vaccine. So there's a difference between these two. The RNA vaccines are absolutely new. We've never had an RNA vaccine before. So there's no doubt that the scientists were able to look in very carefully and make this as a completely new entity. Now, there are others from China and from England, Oxford, AstraZeneca, and then again China, and of course, the Sputnik vaccine from Russia. Now, obviously, there's a lot of data. For instance, Sinovac in a study from Brazil was probably not effective. Only 50% of the patients develop immunity. Now here, AstraZeneca has been used, there's no doubt. And there's no doubt that India, I have to tell you, has supplied 45 countries and millions of doses they were able to make of this vaccine. They have their own vaccine also, Covishield, but this vaccine is now being given to 45 countries, including being given to the WHO that is distributing. Unfortunately, as you know, the developing countries and the poorer countries are far behind. And this is a major, major issue looking at world health. They are not getting the vaccines. But I think there's no doubt, India, for instance, there's no doubt, has supplied majority of these AstraZeneca to the developing world. Now, very quickly, as I said, Pfizer, Moderna, and Johnson, it causes not only the immunity from B cells, B as in boy, but also the memory of the T cells that are critical in the immune system associated with vaccines. Now, the side effects are there, but there's a lot of safety information that is available on all these. And Johnson & Johnson, as I said, is a single dose. Efficacy is a little lower, but vaccine hospitalization rate, 93% of the patients were not hospitalized. And of course, this particular vaccine was used against the strains in Brazil, Nigeria, and South America. So there's no doubt, South Africa. So there's no doubt that likely that this is one that has been investigated against the variants, and it has been quite efficacious. So Moderna and Pfizer, as you can see, are 95. The cost is significant, $33 and $20. It's only $4 from the vaccine made in India, 250 rupees, which is $4. So no doubt that this vaccine that is made is being given free as well as being given to WHO to be distributed to the poorer countries, especially in Africa and Southeast Asia. Now, there are 4 phases of vaccine being given. Everybody knows it. 1A is healthcare personnel. 1B is frontline people and persons over 75. 1C is persons between 65 and 75, and those people with comorbidities. And then lastly, everybody else, especially people below 16, children. So there's no doubt that this is the formula. Now, safety monitoring is critical. So there are at least all these monitoring systems that if you get the vaccine, they have very good systems of monitoring what each vaccine is doing. So the United States, public health, FDA, everybody is involved in looking at this. There are indications and contraindications. Now, if you are very allergic, anaphylaxis with another vaccine, you cannot use it unless you go to an allergist immunologist. But if you have some history of an allergic reaction to a vaccine or other injectables, then you have to be very careful. You should consider going to an allergist, immunologist, and you have to wait at least 30 minutes. But if you've got food allergies and all that, which I've listed here, to food, pet, insects, etc., family history of allergies, there's no contraindication. You get the vaccine. You have to wait there for 30 minutes and you monitor very carefully. But you have to give this history before you get the shot. They will ask you in details as such. Now, unfortunately, there is a big anti-vaccine movement, unfortunately. I don't know, but in one report, which was very frightening, 31 million people were following these anti-vaccine groups. So this is a very sad situation that there is this propaganda related. And of course, the government is trying. This is a little cartoon between two little creatures. Are you going to get vaccinated? You're crazy. They haven't finished human trials yet. So all this kind of stuff is being said. Now, my last slide is very clear. It tells us what is going on. Living things do not serve man alone, nor do they follow our laws and read the textbooks that we write. They are forming continuously, changing, adapting, interacting, interdependent of communities, and this is part of nature. So one needs to recognize that, yes, the earlier we discover that this new virus has taken over and we take steps to control it, but can we prevent the future? I don't know whether that is going to be possible, but we hope that we can do that. Now, as prevention, this morning, the CDC has said, as you all know, I presume, although I'm a little doubtful of some of those things, that if you've been vaccinated and your family has been vaccinated, your friends have been vaccinated, all of you, you can probably get together without a mask. But I'm worried about the variants. We don't know as yet. So I would take some precautions, but they claim that you don't need to wear a mask if you're vaccinated. So I'll put a big question mark on some of these CDC recommendations, and maybe they'll change or they'll continue to be the same. I'm sorry for going on for so long, but I thought I'd give you a little comprehensive view of this problem. And I can't predict, nobody can predict whether this will be the last of the pandemics. As you know, in the past, they've had major pandemics where there have been 20 million. I don't think that will happen because our technology is improved by very significant. But at this stage, we don't know what this virus will be doing. I'm not trying to frighten you, but I'm a little worried about the variants. Thank you so much. I'll end here. Any questions?
First, I want to thank you very much for a very informative session. I have a question.
Yeah.
After you have taken your second vaccination, is there any way that you can be tested to make sure that you do have an antibody that it worked?
As I told you, these are not FDA approved. However, a lot of people want to know. Now, majority of people will get. But the recent data suggests that if you're a male, unfortunately, if you're obese, if you have underlying disease like diabetes, etc., it is possible that your immune system may not be as active as the younger folks. So you can do an IgG-IgM, but chances are, at this stage, it's impossible to predict how much protective antibody you'd need to fight this infection if you get it. Chances are that you're not going to end up in the ICU intubated if you've had the 2 shots. It'll be very, very, very rare. 95, 98% protective. But there are some individuals that may not have a good immune response. So it doesn't mean that you're going to be totally neglectful. If you get any symptoms that are associated, even though you have had shots, I would definitely contact a healthcare professional. Knowing that you've had a shot, you may have flu, or you may have metapneumovirus, or you may have RSV. There are 14 other viruses. So there is no doubt that some of these viruses can be major problems, especially in the older population.
Raj, one of the questions that we've gotten on chat is, can the swab testing today detect some of these variants?
Yes. In fact, the routine test doesn't do it. You have to go to a special lab, and apparently, I think this $1.9 trillion that is being passed, they have now set up areas of the country where these labs are being tested. So the ordinary lab can tell you, for instance, my wife works as the director of one of the labs. If you have 3 areas that they look at, if 2 are present and the third one is missing, especially against the spike protein, which is, those little things that are coming out, then you have to immediately be aware that there is a possibility now you have a variant. And obviously you have to send it to a very special lab, usually the state health department. And if the state health department cannot do it, they send it to the CDC and other special labs that will do further studies to determine what kind of variant they have. That was done in New York. They took all the specimens and they ran these tests, and they found this New York variant in Dr. Ho's lab in Columbia. So there is no doubt that people are doing a lot of work trying to determine where are these viruses, what variant it is, and the 3 components. Are they more contagious? Are they more deadly? And do the vaccines work against these viruses? Everything is a big question mark at this stage. That's the problem. If somebody says, I know everything about corona, forget it.
Another question we have is, one person had asked, if you were doing an antibody test, is it able to distinguish the difference between having a severe COVID reaction versus if you had had just a mild case of COVID in terms of the amount of antibodies you may have developed in your system?
That is true. There is some early data suggesting that if you have very high levels of IgG, IgM, neutralizing antibody, that your immune system is relatively intact. But I can warn you that as you grow older, the immune system in older people becomes dysfunctional. So your immune system may not respond. And if you have obesity on top of that, or if you have underlying other morbid conditions, there's no doubt in my mind, because I've had this experience personally with flu. I got this big flu shot 2 years ago, and I thought I was protected. There is no antibodies that you can really test for flu, very difficult. But I ended up with flu. And I said to myself, what's going on? Sure enough, at my age, I don't have that immune system intact, totally intact, in spite of the high dose flu vaccine that I had. The same thing probably may occur with these other vaccines. And that is well known in older people and people with obesity and other comorbid conditions.
Another question is, if you've recovered from a mild case of COVID or just having COVID, how long do you need to wait when it's safe to be vaccinated?
About 3 or 4 weeks, depending. About 2-3 weeks minimum.
Also, can you comment on the use of Tylenol or NSAIDs before or even after you've received the vaccine?
Yeah, Tylenol is probably okay, but what they call the NSAIDs probably should not be used. And most of the time, the reaction is not major. You may have a little fever and you may have a little pain, but I think sometimes people overdo it and keep taking, large quantities of NSAIDs, Aleve or whatever they take. It's probably not advisable because these can potentially suppress the immune system.
I have a question.
Yes.
Can a person who's had severe COVID, who's been in the hospital for 10 days, can they, which we understand they cannot be contagious anymore, can they still spread virus asymptomatically to other people?
Yes. It's impossible to predict. Even if you do a PCR test, it may be positive. You may not have the active virus, but people have shown that this virus can linger on for a long time. Long time. So there's no way to predict that in a given individual, the virus has totally been eradicated by the immune system.
So they can pass it on, is what you're saying, even though they are not contagious themselves.
Yes.
Thank you.
We have a follow-up question to the NSAID question, which is, how long after being vaccinated is it safe to begin to use ibuprofen if you have the usual aging aches and pains that we all have?
Yeah. Okay. There is no hard data, but I would say 3 or 4 days at least, because once the immune system starts working, and it's usually within a couple of days, although the long-term effect may be for a long, long time with your T cells, but most of the time, within a couple of days, I would say if you can avoid it for 4 or 5 days, that would probably be okay.
And how long should somebody expect their arm to be sore at the point of injection?
Oh, very variable. There are friends of mine who've had nothing. I had it for 1 day.
10 days unusual?
Yes, little unusual. Now, obviously, you're putting a needle into a muscle, and the muscle, as you know, has blood vessels. Unfortunately, sometimes you accidentally may hit a small blood vessel and you may get a blood clot. So they are very, very unusual. But 10 days is stretching it a little bit.
Is it okay to take the second dose earlier than the 3 or 4 weeks?
No. Now, in England, for instance, people have delayed and shown that even after the usual 4 weeks, they have waited 8 weeks. And they have shown that the immune system is still very reactive. So the question is, because they did not have enough vaccine in England, they delayed the second shot and gave the second shot to others. And so far, what they've shown in their data is that it hadn't make any difference.
Can you take it 1 or 2 days before the exact 3 weeks
Yeah.
or 4 weeks?
Probably 1 or 2 days doesn't matter, but I would prefer that you wait
Wait
at
until
least
after.
weeks, yeah.
Thank you.
Jay, you have a question?
Yeah.
You have to unmute yourself, Jay.
Pardon?
Jay Sethi has a question. He's got his hand up. He's waving.
Okay.
Jay, you have to unmute yourself.
Hold down the space bar. Touch the space bar and then you can talk.
My apology. Yeah, there's a old drug that you know is fluvoxamine, which has been in the marketplace for a long time.
Which
And
one?
there was a study, and they just did a parallel study. It was not a double blind, but they found that there's an oral tablet, and that they found that there was effectiveness that it could suppress the virus, replication. So you think that might be doable, like the Merck product they're looking at?
What was the name of the drug you said?
I think it's fluvoxamine. It was just a couple of days. I think it was either on the 60 Minutes or it was maybe a day or two earlier on some special program.
Yeah, we are all burnt with these statements. Unfortunately, unless it's what we call peer-reviewed data. That means a group of scientists who have looked at it in every aspect, torn the data completely and looked at it. You cannot say that that particular drug is effective or not. Now, because what will happen is that if this rumor spreads, then unfortunately, all kinds of nightmares can occur. I mean, even with hydroxychloroquine, there was really no data. And unfortunately, thousands and thousands of people got hydroxychloroquine. And hydroxychloroquine is not a totally safe drug. So one needs to recognize that these rumors that are started or inadequate data, scientific data, can do more harm than good. Be very careful.
What Jay is referring to was a report on 60 Minutes that was published in JAMA and in fact is scheduled to go into a large-scale study very shortly.
Yeah, okay, I read that. But the question is, unless it's tightly controlled,
Yes.
it's impossible to predict, because all these medication, even remdesivir, the latest article on remdesivir is in the Annals of Internal Medicine. That's like, considered one of the most important journals for medicine, other than New England Journal of Medicine. Guess what they are saying? The word was maybe. Now that is frightening, isn't it? The remdesivir that's been used by thousands, the word was maybe effective. So, one wonders. And these are very expensive drugs, some of them.
Yeah, because they're not carefully controlled double-blind studies on thousands of patients. I think
Yes, exactly. And that information has to be dissected completely by people who are experienced in looking at the data. Lance, what happened? The New England Journal had to withdraw 2 major articles.
Wow.
We have time for one more or 2 more questions.
Okay.
There are no more questions on the chat.
All right.
All right, thank you, Doctor. It was a
Thank you.
very good presentation. I'd
All
like
right.
to thank you for taking the time out tonight and doing this presentation to all of us. And it was very clear. It was very good. I think you put it down to all of our common knowledge and taking the time to answer all of our questions.
Thank you. And just keep safe, because as I've warned a lot of people, one cannot predict. I hope and pray the vaccines all work. Maybe we'll get herd immunity, but please be very, very careful. Thank you for listening.